Benign prostatic hyperplasia. Bladder outflow obstruction is the commonest cause for a urology consultation. It is not synonymous with benign prostatic hyperplasia. It just means obstruction to the outflow from the urinary bladder and needs further evaluation. BPH is defined as a nodular growth of varying combinations of glandular and stromal proliferations. It occurs in all men who have testes and who live long enough. Based on this definition of BPH, three types of BPH have been described. Microscopic BPH. This refers to histological evidence of BPH and occurs in 25% of men between 40 to 50 years, in 50% of men between 50 to 60 years, in 65% of men between the ages 60 to 70, in 80% of men in the 70 to 80 age group, and in 90% of men over 80 years. Macroscopic BPH refers to clinically palpable enlargement and is less than microscopic BPH. Only 25 to 50% of those with micro or macroscopic BPH will progress to clinical BPH. Since perception of symptoms varies, clinical BPH again is difficult to define. Attempts have been made to describe them on the basis of symptoms, urodynamic studies, or on the basis of rate of prostatic surgery. This varies in different communities, and in men in age group from 55 to 74 may vary from 5% to more than 30%. At 40 years, the prostate weighs about 26 grams. It grows at a rate of about 6 grams every 10 years. Some studies have noted a doubling time of about 4.5 years. These observations are obviously inconsistent. However, what is relevant is that there is no linear correlation with symptoms. Lowsley, based on studies of human fetal prostate, originally described the lobar configuration of the prostate. A posterior, two lateral, an anterior, and a middle lobe were described. Although inaccurate, it was used for many years because it seemed to correlate with endoscopic anatomy. In adults, such lobes do not exist, and McNeal and Associates described the zonal anatomy. Urethra divides the prostate into anterior fibromuscular zone and posterior glandular zone. The glandular zone has smaller central zone and a larger peripheral zone, where the carcinoma normally develops. BPH nodules develop from 5 to 10% of the glandular tissue proximal to the verruca, called the transition zone. A cylindrical smooth muscle at the level of the verruca separates the urethra and the glandular prostate tissue and forms the sphincter. The smooth muscle layer extends further proximally and contains the BPH nodules. The transitional zone has two lateral lobes and enlarges with BPH. There is a tiny periurethral zone from the verruca to the bladder neck containing glands entirely within the smooth muscles. The central zone lies between the transitional zone and the peripheral zone. Clinical BPH arises from the transitional and periurethral zones, and the compressed glandular tissues form the surgical capsule. The etiological factors responsible for BPH nodule induction and further development are unclear. However, the following have been noted in various studies. BPH does not occur in men castrated before the age of 40 years. Androgen deprivation reduces prostatic size. Testosterone is converted into dihydrotestosterone in the prostate. Earlier, abnormal accumulation of dihydrotestosterone was suggested as the cause. Interference with testosterone, DHT, androgen receptor binding and metabolism reduces the size of the prostate in 20 to 30%. Various theories have been put forth for etiology. The stromal epithelial interaction theory attributes development of BPH to the disruption of the delicate stromal epithelial balance. The ratio of stroma to epithelium is 2:1 in normal prostate and could be up to 5:1 in BPH. Stem cell theory postulates decrease in rate of cell death as a reason for development of BPH. Static and dynamic components. Stromal and epithelial cells comprise a static component along with the extracellular matrix. Androgen ablation decreases the epithelial cell population. Alpha-1 receptors in the smooth muscle add the dynamic component. Prostatic intraurethral pressure can be reduced up to 40% by alpha-adrenergic blockade. Symptoms. Earlier these were described as prostatism and were subdivided into obstructive symptoms like hesitancy, poor stream, intermittency, and incomplete voiding, and irritative symptoms like daytime frequency, nocturia, urgency, and urgent continence, and dysuria. Recently, a different set of terminologies is used to describe these symptoms. LUTS, or lower urinary tract symptoms, is used instead of prostatism, as the latter implies prostate as a cause. They are then divided into filling and storage symptoms and voiding symptoms. The signs. Anatomic enlargement of the prostate on clinical examination is suggestive. Hematuria can occur due to bleed from dilated veins over the prostate. Secondary changes in the bladder include wall thickening, trabeculations, diverticulae, calculi, and signs of azotemia. Upper tract changes include hydroureter and hydronephrosis. Urodynamics. Patients with clinical BPH exhibit decreased mean and peak flow rates. An abnormal flow pattern characterized by long plateau and elevated detrusor pressures at the initiation and during the flow. They may or may not have residual urine. Long-standing obstruction could lead to bladder hyperactivity during filling. Bladder pressure studies are necessary to differentiate between patients with high pressures due to obstruction due to BPH and those with symptoms due to inadequate detrusor contractility. Urodynamic obstruction, unfortunately, does not always predict good results with surgery. Residual volume. If there is significant post-void residue, bladder pressure studies are essential to find out whether this is due to poor detrusor contractility or whether there is obstruction. It is an indication for surgical treatment if there is obstruction. The most popular non-invasive method of measurement of post-void residue is the ultrasound examination. However, for volumes above 100 ml, the error could be as high as 25%. It is important to note that absence of significant post-void residue does not rule out severe obstruction, and also the fact that 30% of patients retain this impairment post-operatively.